Good afternoon. Welcome to the return of Ira Byock to Dartmouth-Hitchcock. And what better occasion to have Ira come back than the planned opening of the Jack Byrne Center for Palliative and Hospice Care, which will be dedicated this weekend and which will open for patients in December. And before I give an introduction of Ira, which will be unnecessary, but I will take the prerogative of doing, I just want to welcome the Byrne family to this room, to this place, and to thank them for their generosity in making all of this possible. So as I said, Ira needs no introduction, but he's going to get one anyway. It's really a delight to welcome him back to Dartmouth-Hitchcock. He's spent the day, I think, seeing the abundance of good things that have grown out of seeds that he planted during his 10 years here. We have an active, vibrant, interprofessional team that's practicing palliative care throughout this hospital, from ICU to pediatrics to the emergency room. And really, he was the architect of the Jack Byrne Center, which will be dedicated this weekend, taking it from what was recognized as a need in the community and turning it into a dream that could actually be realized. Ira and Yvonne, his wife and partner, really helped us move it from idea to reality. So we're really glad to have him here to celebrate that realization of that dream with us. Now, if Dame Cicely Saunders, Elizabeth Kubler-Ross, Balfour Mount were some of the giants, the founders of the hospice and palliative care movement, Ira is really one of their heirs. He is a true patriarch in our field. He's been a passionate advocate for whole person care for people living with serious illness and even not yet living with serious illness. He's takes as his audience not just his colleagues, not just students of medicine or nursing or other healthcare, but patients, their families, the community, writing not just scholarly papers, but op-eds, books, addressed to the public, trying to increase the capacity of all of us to care for each other in the face of serious illness. And many of you, I know, have read some of his books, Dying Well, The 4 Things That Matter Most, The Best Care Possible. I'm sure it will surprise no one that Ira was recognized as a visionary by the American Academy of Hospice and Palliative Medicine. And they gave him their Lifetime Achievement Award in 2014, to which he responded, "Not yet, I haven't." So I'm interested, and I got a little bit of a window into some of the work that he's doing now in California with the Providence healthcare system to see what this next lifetime is going to achieve, and I'm excited to see that. He left DHMC to be closer to his 2 grandsons in Southern California, and their parents happen to be there too. And since then, he's founded and is the chief medical officer for the Institute for Human Caring of the Providence St. Joseph Health System. And he continues to travel widely, writing and speaking and giving us messages like the one he'll give today. And just to close on a personal note, Ira was a big part of my transition into palliative and hospice care. And I've learned so much from him about how to put the person and the family at the center. And I guess I'll just share one particular learning that I've been learned over and over from Ira, and that I've been putting into practice every day, including today, between lunch and now when I was in the ICU, that the patient gets the diagnosis, but the family and the community shares the experience of the illness. And when we take care of a person with serious illness, we really want to take care of their family and, in fact, their whole community. So, Ira, it's such a pleasure to welcome you back, and I look forward to your words of wisdom.
Thank you. Hi, everybody.
Hi.
My deep gratitude for being here today for this a remarkable event. I'm so grateful. I feel so honored to be giving remarks and privileged to be among you. Thank you. There are so many people to thank. First and foremost, Jack, for his generosity, his belief in this project. I miss him. I came to really love him, enjoy him. Mrs. Byrne, for your generosity and steadfast support for all of this. It's a remarkable effort. Your family, all of the donors in the room who made this possible. Thank you so, so much. Also, the people who shepherded this, Jim Weinstein, thank you very much. Ed Marins, Dan Jansen, Gail Dahlstrom, Ellen Bassett, Kathy. Thank you very much. And looking forward to this remarkable event and sort of seeing it from its inception, Yvonne and I oversaw the feasibility study for this and tried to develop a business plan. And early on, it seems a long time ago, it was a long time ago, I found myself reflecting on the most basic elements of human caring. And I thought back about what we know about our earliest forebearers. You know, millennia before there were professions, before there were doctors and nurses, before there were rabbis and priests and imams, human beings were caring for one another. Caring is an impulse shared by many species, not just humans. Most animals, all mammals, care for their young. However, human babies and toddlers are utterly dependent, utterly vulnerable for far longer than the youth of any other species. Similarly, other mammals, of course, tend to their injured and ill, but Homo sapiens are unique in being able to devote so much effort over such prolonged periods of time, caring for, tending their most frail and dying members. It is part of what makes us human. It is a species-specific, and I would assert species-defining characteristic. Earliest human beings lived in tribes and rudimentary communities. Communal bonds were mostly evident during times of danger. When hurricanes or blizzards or floods threatened people's lives, they turned to one another to weather the storms. Primitive people instinctively knew that the safest way to get through the most difficult, dangerous times of life was together. It felt natural and only right to do so. Said conversely, it would have felt unnatural, unwise, and wrong not to look after one another. The biologist in me would say that primates evolved to look after one another. That's, it was a survival advantage. But caring is actually written into our genetic code long before it was etched into biblical commandments and covenants. Growing up as a Jew, I came to understand the Abrahamic covenant to mean that we not only belong to God, but we belong to one another. We lived in community. Whether one considers it the result of evolutionary pressures or God's will, it is indisputable that we human beings matter to one another intrinsically. Two corollaries are pertinent to this basic fact, are fundamental to the ethics and the practice of human caring. First, it is natural for people to live in community with one another rather than merely in proximity to one another. Community is a verb, in a sense more than it's a noun. Second, within human communities, social responsibilities and self-interests are intertwined. In a healthy human society, your well-being matters to me, and my well-being matters to you. I cannot be entirely well if you are suffering. Human beings come to each other's aid in times of need, therefore not merely because they are taught that it's the right thing to do, but also because it would feel unnatural and unhealthy to do otherwise. What I've described is observed reality. It's verifiable. It's anthropology. But there's also a subjective reality, what people feel at times of another's need. Emotionally, the primal human drive to come to the aid of another is experienced as love. This is not an assertion, nor a romantic philosophical notion. It is instead the synthesis of findings from anthropology, ethology, or the study of animal behavior, functional neurology, brain chemistry, brain physiology. Within the physiological substrate of Homo sapiens, the instinct of mattering to one another is subjectively experienced as deep filial affinity. In plain speak, it's love. In contemporary ethics and healthcare, love is infrequently discussed as a motivation for human caring. I suspect that reflects an unspoken assumption among clinicians and ethicists that basing academic discussions on emotional drivers of behavior, particularly love, risks appearing non-scientific. It is, in fact, however, an inarguable fact of human life that people have an intrinsic need to love and to feel loved. The Beatles sang, "Love is all we need." I'm not so sure, but love is essential for human well-being. It's an intrinsic and irreducible part of human well-being. Experienced clinicians recognize that even in the context of significant physical discomfort, social deprivation, the subjective fulfillment of love can engender a profound sense of well-being in the sick person. Conversely, even in the context of physical health and social privilege, feeling unloved can engender profound suffering, as can being frustrated in one's inability to express love to someone else. In early life, we know from many lines of experiments that a paucity of love gives rise to failure to thrive. It used to be called hospitalism, which can be lethal to neonates and infants and young children, in spite of more than adequate nutrition and hygiene being cared for otherwise. So too, during the normal dependency that accompanies late life, an absence of love can make life not worth living. Recognizing love as essential to human well-being and as a motivation of service to others integrates biological, physiological, philosophical, and theological lines of thought, and underlies the universality of ethics and of practice of human caring. I was taught from the Old Testament the story of Abraham emphasizing his covenant with God that binds people in community. In the New Testament, Jesus went further, emphasizing that love is the most authentic human emotion, and service the fullest expression of love to one another within community. In antiquity, love and service gave rise to the professions of medicine and ministry. Thankfully, these highest impulses, love and service, remain driving forces within healthcare today, bringing students to this field despite arduous training, keeping us in this field despite not always easy experiences. But the basic facts of caring are not confined to any profession. The rudimentary elements of service to a person who is seriously ill or injured or aged and infirm are held collectively by us all. Providing shelter from the elements, offering food and drink, helping people with elimination, keeping company with others. These cannot be delegated to any profession. Instead, in a healthy human community, people say to an ill person in fellowship, "We will keep you warm. We will keep you dry. We will help you to eat and to drink. We will help with your bowels and your bladder function. We will keep you clean. We will accompany you through your time of need." Contemporary healthcare complements these basic elements of human caring by providing treatments that counter the effects of trauma or disease. Curing when possible, preserving life and function when possible, and comforting always. Although excellent healthcare is obviously important for providing the benefits of medical science and technology to a person who is seriously ill, it is not sufficient. Essential components of human caring are more important still. In fact, they define fundamental social responsibilities, responding to our instinctual obligations, as well as the core teachings of our ethical and faith traditions. Yet these elemental components represent the floor, the minimum obligations, rather than the fullness of human potential of caring. Beyond that minimum, while by no means exclusive to any healthcare specialty or discipline, to my mind, palliative care and hospice stand out among the specialties for the emphases they place on inherent human dignity and worth, and to the extent to which they embrace the values of love, service, and community. While mainstream healthcare is largely defined by transactional diagnostic and therapeutic services it brings to patients' medical problems, palliative care and hospice advance a relational model of service. They see each patient as a whole person who deserves not only competent diagnostic and therapeutics, but also comprehensive attention to his or her bodily function, bodily comfort, functional capacities, as well as his or her emotional, interpersonal, social, and spiritual well-being. Ethicist Lori Dorfman observed the remarkable potential of this relational mode of caring. She said that each of us will die is inevitable. What must come to be understood as miraculous is our ability to love and bear the weight of the dying in fellowship. In meeting each seriously ill person as a whole person, our basic responsibilities can include keeping company and expands to encompass the ability to bear witness to the other, Beyond providing for the biological necessities of life and medically competent care, in fellowship we can say to the other whose life is threatened, we will bear witness to your pain and sorrows, your disappointments, as well as your accomplishments. We will listen to the stories of your life, and we will remember the story of your passing. This is accompaniment in the truest sense of the word. This perspective enables clinicians to recognize that the potential for human development persists during illness, debility, dependence, and one's dying. Beyond the basic obligations we have to our fellow human beings, our responsibilities, hyphenated, extend to preserving opportunities for people to grow, to develop individually, and to grow together through this difficult time. Death is inevitable. However, forgiveness, reconciliation, and healing all continue to be possible. Years ago, I learned that before concluding a review of a patient's symptoms and concerns, I could ask, and how are you within yourself? People understand what's being asked. In listening to the responses to my questions, I discovered that people can remain or even become well within themselves during this most difficult time. It takes competence, it takes listening, it takes accompaniment, it takes love. This fuller understanding of the human condition engenders a more complete concept of beneficence, which aspires to preserve opportunities for people not just to avoid suffering, but to flourish within their families and communities through the end of life. This new center, the Jack Byrne Center for Palliative Care and Hospice, is a shining example of community in action, of community as a verb. It would not have happened without you mattering to one another, all of us here in this community. This did not have to happen. Right? The feasibility study Yvonne and I oversaw documented significant unmet need, medical need, but also social needs. People sometimes get stuck here for the right reasons. They come from far north country or across northern New England for treatments that offer them some chance of getting better, living longer. And the effort is good, but for whatever reason, their care becomes so complex and their needs so great that they can't get home. They don't need to be in the hospital, but they need complex levels of care. Sometimes even with careful planning and shared decision-making, people's illnesses unfold in ways that make it just infeasible for their family to care for them. Or the family's social situation makes it infeasible to be caregivers. They need to be family. Jack Byrne cared for, Dorothy Byrne cares deeply about this community, about the people of the Upper Valley and of northern New England. With their generosity, but also by their example, so many others of you, of this community, came forward to contribute their time, their money, but also their creative energies, their emotional investment in seeing this through. It's not the money, after all, that really matters. It's what the money will do. What you have built will change so many lives of people in this region. Each of us has a story. Our lives are narratives still being written. So many people, the end of their mother or father's life, their grandparents' life, their spouse or child's life, is a story of unnecessary suffering. Through no ill intention, because the healthcare system sees medical problems, not personal experience. This center will enable people who are seriously ill to receive state-of-the-art care for their medical problems, but also their comfort and quality of life. It will enable their families to receive the support they need to be family, sharing in this illness. What makes this exemplary within healthcare is our intention to go beyond the basics, to meet each person as a whole person within the community. Beyond that, this new center will enable research to go forward, to broaden the evidence base for the disciplines related to hospice and palliative care, to look at outcomes of care, individual and family outcomes, but also outcomes within health services used during the last part of life, outcomes on our stewardship of limited resources. It will allow us to shine an example of what is possible in real-world America, despite all of the challenges and the turmoil of healthcare. It will allow us to teach another new generation of medical students and residents a model of human caring that is expanded well beyond the restricted, problem-based, transactional, fix-it model of healthcare. They will get to see that the best of human caring includes, yes, the state-of-the-art of medicine, the science, but also being able to meet each person, see their inherent worth and dignity, deserving of our knowledge and technical skill, our accompaniment through the very end of their life. These attributes of palliative care affirm the healthiest of human drives and core tenets of our traditions. In our commitment to care for others expertly, as well as tenderly and lovingly, we evince the fullness of human life. In the highest therapeutic principles and in so doing, we complete the covenant inscribed within our genetic code and those biblical commandments. The work that has been done to develop and build this amazing new center, and the caring that will go on within its walls and on this campus, to my mind, completes all of us as human beings. This is the fullest expression of a healthy human community. I congratulate you on this accomplishment. It could not have been done many places in this country. Thank you for the work that you do, for the work that you will continue to be doing. All of us across the country will be looking to your experience and holding this community and this new center up as examples that others can follow. Thank you.
Thank you, Ira. That was inspiring, as always. And I'm wondering if maybe we can pull a couple of chairs
Sure.
over and take some questions from the group. We've got a full half an hour to answer questions. I'm here to answer some of the specific questions potentially about the Jack Byrne Center, and Ira is here to answer questions about what he's doing and anything that's on your mind. Do we need to take...
I think Dorothy will, is there another mic there, right there?
I can carry this one around. So, any questions? Oh, and it's okay, because in palliative care, we spend time letting silence.
We are very comfortable with silence, so we can just sit here.
Sometimes
It's okay.
Sometimes it takes a few minutes to absorb a message, and reflection is good.
Thank you so much. That was great. I have a question about the center itself. I know there's a limited number of beds that will be available. How will you determine who is eligible, how will you prioritize who's going to be able to use those spaces?
Thanks for that question. So the center was designed to care for people who have opted, for the most part, to enroll in hospice, and who would like to be at home getting care that makes every day as good as it can be for usually a limited amount of time, but whose symptoms escalate to a point where even an excellent hospice agency working with nurses coming into the home, social workers, chaplains, can't manage those symptoms at home. Right now, people that run into that problem have limited options. They can stay at home and have their symptoms not managed fully, or they can come into one of our wonderful inpatient units that do a really good job of providing acute care, an amazing place, but aren't very much like home. The center was designed to provide a home-like environment where people can get state-of-the-art symptom management and ideally be able to then return home to live out the rest of their time where they really want to be. Beyond being able to care for people's intense symptoms, we will have programs to try to help the caregivers learn additional skills that they need to be able to manage at home, and to give them a little bit of a break with some care for them, because as I said earlier, the family experiences the illness sometimes even more than the patient does. And so an opportunity for better symptom management and care of the family. How we will prioritize will be based on need. I think ideally it will be mostly people who are at home with hospice who need a few days to a week of intensive management. But we'll take each patient as they come and try to make the absolute best use of the resources available. 12 beds is what we'll be starting with.
What about insurance?
Insurance. So for people who are enrolled in hospice, their hospice benefit will cover the cost of coming into a hospice facility. And we'll be working in partnership with the 3 regional hospice agencies. We've been working really closely with them to try to develop plans for moving in and out that will be as seamless as possible, that will allow them to get their patients in and back home without running into any bureaucracy or logistical challenges. And yeah, that's my promise to you, to do the best that we can with that. And working with those 3 hospices, it's the best chance that we have. They're amazing.
Will our pets be allowed to visit us?
Yes.
I have a question. You kind of answered the question, but I'm wondering what you see as the future opportunities and developments in this field from your perspective, if you could answer that in a little more depth.
Asking me, sir? Boy, there's any number of, that's a long, I can give you a long answer. So scientifically, obviously, there's things to be done around even analgesia, pain control, right? Let's face it, our current pharmacopoeia of pain medications is insufficient and problematic, right? So that's a real frustration, and we have work to do to be able to have new drugs to give people that are effective, that don't have intolerable side effects and don't pose risks of addiction and the like. We have, not only do we need new analgesics, but we need new ways of delivering them, meaning health systems and teams. Currently, reimbursement structures don't pay for For instance, pain management teams that include not only anesthesia and clinical pharmacists and doctors and nurses, but also occupational therapists, physical therapists, counselors for just adapting to chronic pain, for instance, all of that. There's so much I could say. Let me say what I'm particularly focused on is trying to take the attitude, knowledge, and skills of palliative care and use it to transform healthcare in general, the experience. In a sense, if you think about it, hospice in the late 1960s and 70s and early 80s really showed that people who are seriously ill can be well supported, even with complex needs. Their families supported, and they can fairly reliably, with good hospice care, die very gently and have almost paradoxically very good quality of life in many cases, not all, but many cases. Palliative care grew from that hospice base and basically asked the question, well, why do you have to be dying to get it? Right? We've shown that hospice care not only can improve quality of life, but in many cases, when looked at carefully, it actually seemed to allow people to live longer because they were a little stronger, they ate a little better, they slept a little better, all of that. They were a little less anxious. What we're doing now, where I currently work in Providence St. Joseph Health, is we're asking the next question. So, palliative care clearly extends life, makes people feel better, be longer, often live longer. Their families feel better. Why do you have to be seriously ill to get it? Why isn't this just the way we take care of people? Right, a truly person-centered care of people. And it turns out because of the shifts in healthcare financing, which are moving ever more from sort of this fix-it transactional model of medicine to a value-based, longitudinal relational model of medicine, that there's actually a financial case for doing the right thing finally, right? So we're embedding this new model of human caring within the mainstream of healthcare system. It's not easy, and I don't want that to sound glib. It's a process, and because things are that mode of financing is sluggish in coming along, it's a challenge. But we're creating the systems, the microsystems that allow us to do that, right? And we're showing that it's possible. So that, for me, and I think for many of the people, so much of what I'm doing comes from the work of the Dartmouth Institute and so much of the work that's been done here, shared decision making and the like. But we're showing that it's actually possible. We're putting the structures in place and the programming and the curriculum in place and the metrics in place to drive that change. So that feels to me to be a leading edge of all of this.
Would you like to pass to someone else first?
She's here.
Okay, thank you. Ira, you sort of headed toward what my question was going to be, but how we know that hospice benefits exist. Are there such things as palliative care benefits, and how do patients access them?
So there are not specific palliative care benefits of the sort that exist for hospice care. Hospice care has its own sort of carve-out within Medicare. But there are charges, physicians can bill for seeing patients in a palliative care specialty. And there are strong business cases to be made for concurrent palliative care alongside of cancer care or heart failure, because as we're moving toward a value-based model, the better care you can provide with less complications and unnecessary hospitalizations or shorter hospitalizations, the better the providing hospital or health system does. So that it is a cost avoidance model in a sense. Without palliative care, people stay come back to the hospital more frequently. They stay in the hospital and ICUs longer. They often get care that is overly burdensome and non-beneficial, not because anybody is pushing it at them, but because we haven't had that careful and often lengthy conversation that is required to match what their values, preferences, and priorities are with what's achievable outcomes. So that's a long-winded statement to say that it would be nice to have better reimbursement or being able to have benefits that better supported palliative care. And we need it for the outpatient palliative care, certainly. But there is good evidence that even within the current system and in the emerging models, it is highly cost-effective to provide concurrent palliative care.
I have a question for either Kathy or Ira, and it relates to, Ira, what you were mentioning in your introduction about some of the ancient practices. And so this is sort of a historical or anthropological question. We know that people have been dying for a long time, right?
Seems like it.
And they've been being born even longer. And so we have a word for the people that help at the very earliest moments of life, midwives, and I think there's other words. Is there a word for the people who help at the last moments of life?
Yeah, usually it's family. But there are people who use the word doula for accompanying people through the end of life. Some people do borrow from the term midwife, but I think healthcare, doctors, nurses, and others have long accompanied people. So have people, clergy. The professions have long accompanied people. That's what we do. We're service. We are in service to others. So I think our challenge is to reclaim caring for people through the far edge of life, through the end of life, within the normal expectations and breadth of the professions of ministry and medicine.
Okay. I'm going to be my father's son for a moment and ask you an economic question.
Yeah.
Actually, I'll ask you an economic, a pharmacological, and a spiritual question.
Wow, you are your father's son.
Okay.
Wow. I would have a double espresso before coming to that. Okay. This is not for the faint of heart.
He always enjoyed your visits. He really always enjoyed your visits. On the economic question, I'm curious, for a month of hospice care, setting aside what you can get reimbursement for from insurance companies and Medicare and such, what does it cost you to take care of a person for, say, 1 month in hospice? What's the total bill?
There is a range, and there are different categories depending on people's needs, the complexity of their needs. It can be as little as $5,000 a month, but it can be much, much more.
Fine. That's actually less than I'd expected.
Well, that's assuming they have a place to be. Most of hospice care in America is home-based care.
Okay, I'm sorry. I mean in, say, in a center like my father, the center here.
Yeah.
I'm sure that's...
I'm guessing it's going to be in the $16,000 to $18,000 range.
That seems reasonable. Second and third question. So here's one. Here's a pharmacological.
More, huh?
I would have thought 25,000 was a good deal.
It may be. Again, it depends on why they're there. If they're there for active symptom management, and you're needing to do procedures and needing round-the-clock nursing care rather than the more routine level of nursing care, it's probably more than that. Yes.
Okay. Second thing, I have, as you know, and probably a lot of people here know, I've had lots of health issues. I've been stage 4 a number of times in my life, most recently 2 years ago. And people, when they get to know me, always find it, like when they get to know me well enough, they can ask me that one question they want to ask me. it has often been, what is it like? What is it like when a doctor tells you you're going to die? And in particular, the advice I got on several occasions from doctors was really phenomenal. So pretend now that you're having to tell a young person he or she is not going to make it. What's the next thing you tell them on how to deal with it, how to think about it?
You know, the first thing that I think any of us do is listen. This is such an intensely personal experience that just being present with people, just being present and being available, but it's not a time often when people are eager to get advice. They may ask for it, but mostly they're stunned and there's so much to absorb. Life changes so dramatically. So I don't have any stock phrases.
You don't have so, okay, they've gotten over it, they're now ready to listen. Do you have any standard advice you give people? And I can let you off first.
You know,
What's important to you to do with the time you have left?
if God forbid you were to die today, as any of us might, if you were forget about your illness for the moment on the way home from the office, if you were in a car accident, what would you be worried would be left undone? Would there be things left unsaid between you and people who you love in your life? Because if that's a quick sort of environmental scan of one's emotional, what matters most to you. If you can surface that, then the next thing is, well, this might be a good day to write a letter or to pick up the phone or to tell those people the things that matter most and that what you'd want them to know. After doing that, hopefully you're not going to die today, right? You're going to live but you'll likely feel a little less of a burden that there's critical things left unsaid or undone.
Thank you.
Ira, perhaps you can answer this. Unfortunately, like most things in life, underlying everything is money. There's a finite amount of money to go around. Currently, and I suspect for many years to come, the amount of reimbursement that insurance companies and Medicare and any other financial arrangements will pay for hospice care and palliative care is much less than is needed. Now, in order to cut this pie a little bit differently, it seems to me that the medical profession, the surgeons, everybody else is going to have to say, gee, we're making a ton of money here. Palliative care and hospice are not getting enough money. We're going to give some of our money to them. Is this going to happen?
That already happens here. Our organization prioritizes whole person care, and they understand that surgeons do one job and palliative care doctors do another, and that we have to invest in palliative care in order to provide whole person care and whole community care. So I think there is redistribution of resources. We understand that the way the healthcare system finances is set up doesn't make sense, and that we have to use the resources that we have to give the best care possible. I also just look out at the community and they see this problem too, and they want to help build that too. And so, not to say it's just Dartmouth-Hitchcock, but it's really Dartmouth-Hitchcock and our community that are trying to distribute resources to get what they think is important.
Let me just answer it in a different way. I totally agree with what Kathy just said. I would also say that the great Jack Wenberg found years ago that there is a great deal of unwanted variation in healthcare, and much of it is without value. Where we are today with big data, including within the organization I now work with, we can look across this massive health system and we can see surgeons whose cases, standardized cases, are dramatically different in costs without difference in outcomes. Right? The higher costs do not always map to higher quality, and frankly, sometimes just the opposite. So we're, in a very comprehensive way, looking across and using big data and analyses to determine what the best care really looks like, down to what implements you use and what antibiotics you use, and everything. And so there is an enormous amount of savings to be had without sacrificing an iota of quality in the future of healthcare if we're sophisticated enough to make use of those opportunities. There will be plenty of money. There is already plenty of money in our total healthcare budget to support extraordinarily good care and human caring. We're not delivering it. This is beyond a Rube Goldberg current system. We really need to redesign healthcare. And some of us have the privilege, and this place is a shining example of one of them that has the privilege of really thinking creatively about what a rational and really well-designed future healthcare system will look like. I do not feel resource deprived in the work that's ahead. It is day to day I'd like, there's some personnel I'd like to hire and all that, but there's plenty of money to give people truly excellent care.
I think I understand that when you talked about community, typically when someone is dying, there's going to be somebody that's probably a family member, a husband or a wife, that really does the heavy lifting, that's emotionally vested in this person and is there a lot and doing a lot of the caring. And I've seen and talked to people and read statistics that if that person isn't cared for, their life expectancy actually is shortened.
That's right.
So given that fact, I've heard also talk of involving the community in a way, all I've heard is that term, to help that person. So there would be some kind of program someplace to help that person we're caring for the caregiver, so to speak. So I want to know if you have a vision here in this community, if you've seen it someplace else, what that looks like, and if there is such a vision here.
Would you stand up? You. Cease, stand up. Kitty, stand up. These are two of our No One Alone volunteers. These are members of community, right, who show up day in and day out simply to accompany people in this great hospital. Why do you do this?
Because I love people. And it's in my spirit. I have to do something. I'm happy when I do something for somebody in need. And I hope I can do it. My husband is very sick right now. And I still wanted to come here. And I'm so, so grateful to this hospital and to palliative care. Because what he's going through, I can come with such a beautiful way. I'm not saying I don't get angry, I don't get upset, it's normal. But I feel a beautiful strength. And every day I thank God for all that I got from this hospital, from Marie and hospice and this beautiful work. I only have to thank you, and gives me an enormous pleasure. I have to do things for other people. Thank you.
I too love people. I have been in the nursing profession, now retired, for over 50 years, but I feel so much better when I'm involved with people, helping people and loving people. And you'd be surprised how they open up when you will sit and listen. So often they cannot talk to family members. It's very difficult to share your feelings. So a complete stranger like myself and other volunteers can sit there, hold hands, give a hug, and listen. It's so important. And I have lost many members of my family to cancer. And I know what it's like to be the caretaker 24/7 at home. And so to have all of these programs as an adjunct to care and survival of the caretaker, if you will, is so important. And I'm excited about the new building and what will happen there. And I have a question about the Byrne Center. What is the maximum length of stay there?
There is no maximum length of stay. It's designed for people who don't need long stays. Our hope is to return people to their homes if that's where they want to be. But there's no maximum. People will stay as long as they need that level of care.
We're all looking forward to it.
Bob, what I had tried to say in my remarks, my prepared remarks, was that in a healthy human community, our social responsibilities and our own well-being are intertwined. This is human flourishing. This is human thriving in community. We are social animals.
I have a question. I've been a nurse in critical care for 12 years, 8 of which has been here. And while I can say with certainty that my desire when I entered nursing to participate in healing and caring has been fulfilled in that role, I can also say with absolute certainty that I have participated in creating human suffering. And I've seen a lot of excellent nurses leave the bedside because of that real moral dilemma. And I'm just wondering what words of wisdom or advice you could give so that those of us who are at the bedside in those situations can kind of reconcile what it is we're being asked to do, because it's really very difficult.
I'll turn it over to Kathy in a moment. We know this. Thank you for what you do. I think critical care nursing is just beyond amazing. True human caring. Nationally, the #1 reason that critical care nurses leave the field is moral distress. And it is about being complicit in delivering care that is either non-beneficial or unduly burdensome. I, too, as a physician, have been complicit in, responsible for delivering care that was non-beneficial, overly burdensome, and caused suffering. It is not uncommon in healthcare. We do it with the best of motives. We don't do it in any sort of mean-spirited or malevolent intention, but it's common within the system that exists. Many of us are working clinically and programmatically to change those normative systems in critical care particularly to require us to provide not only the best disease treatment and life-extending care possible, but to do so in ways that honor the wholeness of human beings, that pampers them to the extent possible in the midst of all of this. And that first and foremost imposes the absolute requirement that we must know that what we are doing is something that they want done. That what we're trying to do, consistent with elaborated recommendations from critical care societies, is to impose this requirement that it's not quality until there's a formal family meeting or patient and family meeting, if the patient is able to participate, that looks at what the achievable physiological and functional outcomes are, and whether those achievable outcomes would be something that the patient desires, what the patient's values, preferences, and priorities are. When we've done that, even though those of us in healthcare may think that it's not, as a physician, let me say that I might think that it's very unlikely that this course of very intensive treatment for a patient with multi-system organ failure makes any physiological sense. If we've had the conversation and we know that it's what they want, I have less personal moral distress about it. What the protocols are calling for is that every 5 to 7 days in an ICU, you have that conversation again, looking at where we've come from since the last time we met, whether the patient is making progress towards the hoped for goals, and whether what we're doing now is still consistent with what he or she would want, what your family wants. That, I hope that doesn't seem too anemic, if you will, but that in and of itself, it tends to diminish, and there's some evidence base to this, tends to diminish distress among the whole team caring for critically ill people.
Agree with everything, and I'll just add a couple of things. One is that, just for everyone in the room, there's very clear evidence that if your family member who's trying to help make decisions for you in an ICU, when you can't make decisions for yourself, if you've left them some sort of a roadmap of what's important to you in those situations. An advance directive, yes, but a conversation, a series of conversations so that they know where you draw that line, what's of value to you. And I'm saying this, if you live with someone, you probably know that about each other. But many people have children flying in from across the country or children coming in who aren't up to date on what was bringing pleasure to their loved one in the last few weeks. If you can try to keep your family or your surrogate decision makers up to date on what's important to you, that will help guide the care team, that will help you get what you want, and it will help reduce distress for the people working in the ICU and for your own family members as they navigate what's an incredibly difficult situation, trying to carry out someone else's wishes. So just a plug to have those conversations. They can be very rich. And then lastly, I'll just say one of the things that really drew me to palliative care when I was trying to decide, I was trying to get it out of my system and realize that I shouldn't change careers. I should stay in infectious disease and not go through this whole training thing. So I said, Ira, can I come spend a day with you and just see what you actually do so I can move on? So I spent a day. So here I am. I moved on, but not in exactly the way I thought. But one of the things that I really was so deeply aware of was I had been working in this hospital for about 12 years. And as an infectious disease consultant, I moved all around the hospital and I interacted with a lot of people.
Taught us all to wash our hands.
I did. And that was good work.
It was good work.
When I was with the palliative care team, what I saw was Ira stopping to talk to staff. He called them by name. He knew he'd check in with them, not just about their patient, which, by the way, I always do before I go see a patient, check in with the nurse to find out what's going on, what do I need to know. But he checked in with the people, and I think our team tries to check in with the people doing the work. How are you holding up with this ICU patient that has such great needs, or has such a complex family, or is alone? How are you processing this? And I saw you touching people in ways that felt like you were getting below the surface while the rest of us were kind of floating around the top. And I said, I want to do that work. I want to work where there's actually human caring, not just for patients and families, but for each other. And I thank you for that.
Just to tie these two together, it's human interaction that fills us up. That's why you do this work, right? That's why we all volunteer. There are hospice volunteers throughout this community. So many of us volunteers, and not just around serious illness, but pregnancy and foster care and so many things. So we do this because human interaction fills us up. We're not glasses to be drained only by emotional glasses. People say, "How can you do this? Don't you feel drained?" Well, yeah, sometimes, but we're also filled up. Yes.
Hi, Dr. Byock. I appreciate your vision of extending the virtues of palliative care into the healthcare system at large. And you've spoken a little bit about how that's possible from the top down, but I'm wondering if you have thoughts on how it might happen from the bottom up as well, particularly in medical education, and how that might change in order to see your vision through.
Lauren's a medical student.
Yeah, thanks for that. So I think medical education has to dramatically change. I really don't think I still think, although we've tweaked it, I still think we're teaching a largely mid-20th century curriculum. And I think, and we're teaching it in a world in which doctors don't do what they used to do. They do other things now. So I think the clinical curriculum still, and this Geisel is certainly a leading example, but medical education has to keep changing dramatically to meet the needs of the new population, including the fact that, after the last real renovation of medical education in the mid-20th century, things changed. We've invented chronic illness, right? Chronic illness didn't used to exist. People used to die quickly. Cancer was a subacute diagnosis. 3 weeks after the diagnosis, you're gone. Heart failure, the first time you developed pulmonary edema, you were gone. Kidney disease, growing up, kidney disease was fatal. Nowadays, we have various kinds of renal replacement therapies. I could keep going on. My point is that we need to train doctors in different ways. We need to train them to care for not only things that they can cure, because the importance of that hasn't diminished, but we also have to train them to care for conditions and multiple comorbidities, people with multiple medical conditions that aren't curable, but people can live with often very well for prolonged periods of time. We need to train them to work in teams, because healthcare is doctors don't work in solitary practices virtually at all anymore. So it has to change a lot. And I don't have any simple solutions, but I think that asking tough questions of your medical school is important, that all of us have to be active in encouraging this new healthcare curriculum and healthcare experience. And I say this, I'm on thin ice here politically, because it's hard to change medical education. Curriculum is parsed out by departments. It's easier, peace in the Middle East would be easier than extracting a little curriculum time from one department to give, so it's really a challenge, but it does need to change.
I don't have a question. I'm a palliative care volunteer as well as a pet therapy volunteer, but I worked with a hospice program before I moved up here. And two things that I came away from that was that the whole program felt it was a privilege to be involved with a family that had elected to be on the hospice program. And the other thing that they came away with is that the family took the responsibility and the patient was able to focus entirely on themselves and whatever was going on. And the hospice took away all the nitty-gritty, the hospital bed and the meds and the nursing, and let the family deal with the patient directly. And that was very plus.
Thank you.
Thank you.
Thank
And
you all
thank
so
all
much.
of you. Thank you, Ira.